issues that continually challenge us across various stakeholder perspectives and say, in the end, let's keep in mind the example that the president of Mercy Medical Group, Alan Schatzel, brought to us in this room last year. I believe it was February of last year, where he said in his leadership of one of the finest stroke programs in the country that he often receives an unconscious stroke victim for whom he has no data. And often that stroke patient is from one of the major health systems in this area. We only have 4 major health systems here that we need to bring together to share data in order to help that patient to survive. We know that for life-saving treatment, every minute counts. Time is brain, time is heart, and as many of you who do know me know, I not only have been trained on how to use numbers and science at some of the finest institutions in the country, and I believe that we can solve policy problems in that way. You have fantastic materials in your packet. You have data that shows you that in the Sacramento region and the Capital Region, we have a higher incidence of heart attack and stroke, and at younger ages than the rest of the country. But I also come at it from a personal perspective. My father had cardiovascular disease and quadruple bypass when I was in my 20s. And when I was 15, my body double died suddenly of a stroke. She was my mother, and it was a harsh experience. I never would have thought that I'd be working on that topic in my career. It certainly wasn't my intention. I just fell into it through the numbers. And it has been identified in this room over and over and over again that one way we can help those heart attack and stroke victims to survive is by having the timely information necessary for the frontline teams to be able to provide them the life-saving treatment. So with that, I'll just say thank you so much for your many efforts to be here today. I'm looking forward to your thoughts. Thank you, speakers, for being here. And with that, I'll turn it over to Dr. Arevalo, our co-chair. Well, could you just have people go around, please?
Yeah, well, thank you again for coming this afternoon. And as usual, part of what we like to do is to make sure who's in the room. And if we can start out with introduction, maybe. So we have, here's my, maybe we can start out with Joan, who needs no introduction. I got her just at the right time.
Yes, you did.
Yes.
I'm Joan Werblin. I'm a retired UCD nurse specializing in diabetes, and I'm also here representing the California Health Coalition. I'm vice chair of the board of directors.
I'm Martha Garrity. I work for HealthNet. I represent Northern California for Health Education Programs, and I developed a statewide initiative called Healthy Hearts, Healthy Lives, which is a comprehensive heart health campaign focused on prevention and disease management for the state.
I'm Bill Remack. I'm the Business Development Director for the California Chronic Care Coalition, and I'm also the chairman of the California Hepatitis C Task Force.
And an Uber volunteer. Thank you for being here.
Thank you.
Sherry Jeffy, California Chronic Care Coalition.
Susan Ivey, I'm a family physician and a professor at UC Berkeley at the School of Public Health and work on health studies.
Leonard Fry, Doc Ventures LLC and LWF Home Care. We specialize in caring for patients with chronic disease.
Jim Ellsworth with Capital Health Network, a consortium of federally qualified health centers and rural health centers serving
Doug Hart with Cal Index, and I'm here with my colleagues who will be speaking today.
In trying consulting, all aspects of healthcare.
Bob Trine, I've worked inside healthcare since the early 90s in most sectors, most recently as senior executive with Gunderson Health System, integrated provider and everything.
And thank you, Bob, for working to bring Gunderson out to be our speaker next month. They are a top 10 performing health system in the Midwest.
Hi, I'm Steve Durbin from Share Environmental Health and Safety Services. And this is Shisaka with Blue Shield of California, the ACO pharmacist.
Nancy England, also ACO pharmacist for Blue Shield. Yvette Purple, Director of the Advanced Practice Program for Palomar State College of Pharmacy.
Don Forster, medical director deals for health, Earth State, and staff physician with John McDougall.
I'm David Magnino. I'm the acting administrator for the Emergency Medical Services Agency for Sacramento County, and hopefully involved in trying to get our Florida health system to more integrated pre-hospital and hospital data exchange.
Thanks for being here, Dave. New member joining.
Andrew Roger, I'm a pharmacist with Health Physicians.
I'm Doug Robertson, I'm the Regional Administrative Director for Health Physicians here in Sacramento.
Hi, I'm Shelley Bolton. I'm a Senior Health System Executive with Novo Nordisk and Diabetes Care and Population Health in Northern California.
Hi, I am Lauren Snurby. I'm a Senior Clinical Program Manager with ACOs here in the Sacramento area, for Health, and my pharmacy colleagues over there.
Hi, I'm Jody Bartoli. I'm a Regional Nurse Coordinator in Blue Shield, California.
Hello, I'm Justin Gabriel with US Health Center, Vice President of Business Development. We specialize in building predictive analytics for what we call pre-disease, to find people prior to becoming chronic, so that we can prevent disease from occurring or prolonging disease.
Warren Barnes, regulatory consultant, UC Berkeley School of Public Health, and pastor of Grace Presbyterian Church in Sacramento.
Kristen Robinson from Kaiser Permanente in Sacramento, and I'm the Chief of Chronic Conditions Management.
Good afternoon, I'm Sarah Brass, representing the VA Northern California Healthcare System. Lisa Ashton, UC Exec School of Pharmacy.
Val Ramirez, Department of Healthcare Services, Office of Health Information Technology, and I administer the Medicaid EHR incentive program.
I'm Lynette Scott, I'm the Chief Medical Information Officer at Department of Healthcare Services, working with Rome.
Jagdish Goswami. I'm with Sierra Nevada Community Health Plan based in Vasco. We just started building new clinics here in Sacramento, Roseville. We started some in Vasco, where we take medical patients and private.
Hi, I'm Jan Vandermeer. I am the Regional Director for our Ambulatory Care Management Programs. What that actually means is I have embedded teams of case managers, nurses, social workers, pharmacy, and a healthcare coach role in our internal med and family practice doctors throughout the region for our physicians.
David Matsumoto with Novo Nordisk. I'm an account executive with diabetes management and population health management as well.
James Palmieri, faculty with California State University College of Pharmacy and clinical pharmacy specialist with the Community Health Cardiovascular Institute.
Hi, I'm Stan Lemon, I'm a patient care service manager with Safeway Northern California.
Jill Joseph from UC Davis, Bed Harry Moore School of Nursing. I'm Associate Dean for Research, and we're working on some innovative care coordination models, currently focused on the use case of cancer.
Hi, I'm David Eisen. I'm the medical director at Molina. I'm also interested in integrating and coordinating care.
Hi, Randy Barker, Facility Site Review Nurse for Molina, and he's educated.
I'm David Jacobson with United Healthcare, and interested in improving quality and outcomes.
Dan Carpenter, Regional Account Manager with Barringer Farm Services.
Neil Warnock, Health Economics and Outcome Research for Barringer Inline.
I'm Chad Barks of Health Services Advisory Group. Just a couple of items to note. In your packet, you have a CME or CE certificate instructions if you qualify for that, so please don't, make sure you get those. Also, in front of you, you have a little handheld device. You'll have an opportunity to respond to some questions that our representatives are going to have later today. So make sure you have one of those. If you don't put your hand up, then I'll make sure you have one.
And we have one more guest that's just arrived. If you wouldn't mind just briefly introducing yourself.
Hi, Vicki Williams, American Heart Association.
Thank you, Vicki, for being here. It's a big trip.
Well, great. Now what we'd like to do is to continue our discussion with Dr. Ertl, who has done a really nice survey of Mercy Medical Group physicians around hypertension, and he's going to follow up with some data.
I don't know if it's nice.
Yeah, well, we're going to steal it, so next.
Let's see. So where am I going to find this presentation?
So Carla should be in the room. Thank you, Chad. So just to make a segue from last month, Dr. Ertl is our co-chair. He's the head of the Mercy Medical Group, the chief medical officer of Mercy Medical Group. And he has a master's in medical informatics, and he's really comfortable with computers. And he took our huge conversation we've been having over the last couple of years on hypertension, and he boiled it down to a survey monkey of his physicians, and he boldly sent out a survey monkey to the physicians to see, are they aware of the national JNCA guidelines? Are they aware of the National Million Hearts campaign? Are they aware of the Measure Up, Pressure Down campaign? And what are their treatment modalities that they prefer? As just a way to assess anonymously what was happening in his medical group. And that created some news for the medical director to act on. And this is how he took it from there.
So thanks, Hattie. Yes. So what I did is I wanted to be sure. I said this last time. I don't know what I don't know, and therefore you have to ask. And so I asked the physicians what their level of knowledge was about guidelines and what treatment goals were, and kind of first-line therapy, second-line therapy, third-line therapy. And I presented that last time. Well, as the survey showed, there were some gaps in their knowledge, not a huge amount, but some. And so what I did is I followed up the survey. I actually sent the survey results to everybody that not only responded, but everybody that I had asked. Because, if you get 40 or 50% on the survey, you're doing pretty well. So what I did is I sent an email to all of the adult primary care providers with the survey, with JNCA, and a document on how to train for accurate blood pressure measurement. And so remember, part of the gaps that were identified last time were that there were some people that didn't know the treatment goals for under 60 were 140 over 90. There were some people that hadn't realized that the updated goals for those over 60 were 150 over 90. And so what I wanted to do is reemphasize those. There are differences in first-line therapy for African Americans compared with non-African Americans in the United States, and reemphasize that and what the second and third-line therapies are. Some of the summary of the survey findings, a lot of people are on combinations, and that often is first-line therapy where you have low-dose hydrochlorothiazide and something else, and that's pretty common and actually a really good starting point for a lot of patients. The physicians felt that home blood pressure monitoring devices were a good idea. A lot of patients had them, they weren't using them consistently, and they weren't bringing the information back. So that was emphasized, and then encouraging medication compliance, because their belief, the physician's belief, was that the major stumbling block in getting control was actually patient compliance or adherence to their regimen. And then it was also important that we actually take the time to retrain the MAs on how to do accurate blood pressure measurements. A lot of people kind of fudge it. If you get 120/80, it probably wasn't 120/80. And, you know, they should be sitting down, the arm needs to be supported, you're not supposed to be talking to the patient because all of these interfere with an accurate blood pressure reading. So I also put in the email that the Measure Our Pressure Down in the Millions of Hertz campaign has similar goals, that is, save lives, reduce stroke and cardiovascular events, and control of hypertension is certainly low-hanging fruit to do that. I also contacted the lead analyst, Kelly Miller at IHA, regarding what the P metrics are, and they were updated in September of last year, and they put a pure hypertension, not hypertension and diabetes, but hypertension metric in, that reflect the JNCA goals. 140/90 for those under the age of 60 and 150/90 for those 60 and over. So that was interesting to see. And as far as the metric for diabetic patients and control of hypertension, it really isn't a metric goal like 150/90. It really is that are they on an ACE inhibitor or an ARB, because that's very protective for their kidney disease and other microvascular disease.
So can you back up and just talk about that alignment with Medicare Stars?
Yeah, I don't know much about Medicare Stars, CMS Stars. Maybe other in the room know that. I looked at that, and again, I think that the goals in general for diabetics are 140/90, regardless of their age. So, other comments?
Oh, just that the CMS Stars program does give very significant financial incentives for hitting that target.
And then I work with our analysts because we try to provide data in front of our physicians, our providers, in a number of ways. We have a point of care thing that people can click on to see where people have trended, what their blood pressures have been. We typically list a whole variety of metrics. In addition to that, we have a physician dashboard that focuses on 32 of the P4P metrics, including hypertension, to see where they are as a group. You can also drill into individual patients that have failed and are not at goal as a pursuit list. And then we also have a chart preparation document that lists a number of things so that the physician can say, for this patient, this is what I need to do, this is what my MA needs to do, this is what I need to do for P4P and for meaningful use and for HCC coding. So it's a whole variety of things that we try to put in front of people so that they're reminded that, you know, you need to attain goal on a whole variety of things. So, questions? Answers? All right, thank you.
Well, thank you, Alan. And as I think I mentioned as Alan was coming up, this survey, we would like to promulgate it even beyond Mercy Medical Group because we think it's a great tool to help understand what's happening within the region. So we're going to promulgate it within Sutter IPA, and we're working, thank you, with Mary Firmison and Chad to use this very same Survey Monkey. And we're, at least at the first iteration of this, we're going to keep it, the same question so we can have some comparisons. And we believe this is really important to help us as we try to move forward with improving what our doctors and our clinicians understand about hypertension management. And really the focus is around JNC8 and believing that these are the really accepted gold standard guidelines that we should be promulgating. And with that, I think we've had a discussion here at Right Care with some of the Right Care leadership, and with the help of Susan Ivey, Mary Firmison, and several others, we are hoping to put together a process where we can rubber stamp JNC8 as the guidelines that we have accepted and are adopting and recommending to our local clinicians. Recognizing that there are other guidelines that are being developed by, for example, Kaiser, and even Sutter has a guideline of our very own. But to the extent that the target audience really is primary care physicians in the region, and particularly those who may not have a larger organization that's supporting recommended guidelines. And because it's so many and so many different ones, although they tend to follow JNC 7, because there are some controversy around JNC 8 goals, our belief is that if we could step forward and if we come to agreement amongst the clinicians within this process, that this could be very helpful to clinicians, particularly those clinicians that are sort of caught in the middle and are not within their larger organization, and who would benefit from having, an organization like this basically say, these are guidelines that we've reviewed and we believe are the so-called roadmap to improving care for your hypertensive patients. So we wanted to report that, and we wanted to also just give you a heads up, because we believe that it shouldn't just come from this small group, but we'd like to, once we get the tools, which really are tools coming just from JNC8, so we're not going to change anything, we're just going to take the JNC8 tools and modify them or make them more user-friendly, and we need your help as we put these things together. We'll be sending out drafts and then getting your feedback so that eventually we could put a product out there that we could say is supported by the physicians in the Right Care Sacramento or Capital Region Initiative. We think this is a next step amongst many that we will be taking as we move forward to support our physicians. Mary, would you like to make any?
Oh, just a comment. In my experience as an administrator, which has been for a number of years, when communicating with physicians, it seems like you need to have 3 or fewer bullet points, and you better make the most important point in the first one. So I gave the JNC8 to all of my adult docs who treat adults, and that's why I summarized JNC8 for them, because they're not going to read it. And so you have to take the gaps in their knowledge, which were a few, and hit those points, 5 or 6 points, and hope for the best. Because physicians in my experience don't take the time. And so you have to really kind of spoon feed it to them. And so I think that whatever the plan is, we'll find a spoon.
I think particularly around those individuals who are, probably fall within the gap and don't have a large organization like Mercy or Sutter or Kaiser, and there's a lot of physicians out there who would benefit from that.
Thank you. So I just want to add that Health Services Advisory Group, which is the Medicare Quality Improvement Organization for California, is here to support you and to help improve hypertension control. That's our goal for the next couple of years at least. Right now, the blood pressure control measure is showing the best, about 50% of the hypertensive patients under control. So our goal is to improve blood pressure control. And in order to do that, implementing and adopting the guidelines into tools that will help everyday clinicians on a day-to-day basis, implementing it and translating it into treatment and patient engagement and so forth. So along with that, the survey is also an important thing to do to assess where the physician's knowledge is right now. So thank you to Alan for sharing that tool more widely. Any of the physician groups who want to implement that survey, please let us know, and we will help you. What we are prohibited from doing by CMS is to actually implement the survey itself. But we can help you in incorporating it into the SurveyMonkey and also analyzing the results if you need it. So just let us know, let me or Chad Vargas know, email us, and we'll email the survey tool to you and help us assess the current stage of physician knowledge in hypertension management. Thank you. Okay.
Yeah, quick question. I was just curious that, is there any intention of doing a survey now and then let's say going back in a year after you've implemented the different programs to see the difference in the results?
Yeah, ideally I would like to do that, but we'll see how we evolve from there. That would be great. Thanks.
Thank you, Mary. So we like to adopt best practices, and what we have been encouraged to adopt is the best practice of always including a patient story. Now, we've tried this across our different university best practices in California. We have one in Los Angeles, one in San Diego, one here. And our patient today, I think, is going to blow your mind because he is not your average patient. He's a Silicon Valley genius who just happened to become a complex patient. And he just happened to take his patient experience and turn it into something really amazing that can help other patients. So with that, I'd like to introduce Justice Decker, and I'd like to ask Chad to please load up his slides. Justice, thank you for making the trip across the country to be with us.
Wow, it reminds me of something that President Johnson said. He said, I wish my mother and father were here today to hear this. One, that my father would have enjoyed it, and my mother would have believed it. So thank you very much. Wow, this is really unique. Thank you, Hattie Hanley, and the Right Care Initiative, as well as the Department of Managed Healthcare and the Sierra Health Foundation for asking me to speak today. And thank you, all of you guests, many of you whom I've had an opportunity to meet coming in. Thank you very much for the warm welcome. Today I'm here to present the patient perspective of the complex patient, or as when I was going through this last night with my wife, who's a very, very close advisor to me, she said, don't you mean high maintenance? Okay. So the next slide here, we're going to go to, is kind of giving you an agenda.
Does that advance, Chad, or?
Well, we'll just do it
the
normal
old-fashioned way?
method.
Okay.
So we're going to go through these subjects here, and the table of contents. And I'd like to go on and make a couple introductions, if I may. This is the professional me. I spent 25 years in Silicon Valley, where I ran a think tank and design firm, and we designed 65 stents for 35 major medical companies, ISDs, VSDs, Helix septal occluders, and we designed the U.S. Army Land Warrior System, which was a new American digitalized fighting unit, first wearable computers. I was also responsible for the first NASDAQ merger post 9/11, and I'd like to continue on and give you my second introduction, my patient introduction. I'm Justice Decker Gordon. My date of birth is 1/15/53, so you know I just had a birthday and I'm looking forward to early retirement. I am Caucasian, German, and Native Indian heritage. I had a coronary stent in 2001 on my RCA, my right coronary artery, and it was followed by a 4-vessel CABG, which I experienced in February 22nd of 2010. I remember that quite vividly. I'm coming up on my anniversary, by the way, guys. After my bypass, I continued to have an awful lot of issues. And these were issues that, from a patient perspective, a lot of people are quiet about. But I experienced everything from costochondritis to angina to gas to panic attacks. And as you see in this narrative here, it was written by my partner, an interventional cardiologist, I had a lot of issues. And for the next 6 months, it just continued. As we all well know, necessity is the mother of invention. And this was quite relative here because I am a complex patient. On my father's side of the family, all of my aunts and uncles died at 46 from coronary artery disease. I got the special benefit on my mother's side, who was American Indian, diabetes. So this incredible combination of diabetes and coronary artery disease. I'm the typical baby boomer, and I have multiple chronic illnesses. Well, the necessity, of course, is I had no choice but to take action. I was totally engaged. I'm a technology guy. And I went out there looking to provide something or the discovery of a set of tools that would truly be usable for people like me. This was really tough. So I looked for a solution, and all the systems I looked at were not sufficient. There were none of the systems were interoperable. There were just silos sitting there. So I asked myself, do I really want to take this on? Because this was really tough. And I said, is it really worth the effort? And what is the value we're going to get out of it, the patient as well as the healthcare system? I realized I couldn't live this way because, guys, I ended up in the emergency department in the next 6 months after my quadruple cabbage. I ended up in the emergency department 20 times. It was sheer pandemonium. Florence, you know. And this is, the nurses and caregivers are the ones that provided me that support and comfort when I came in, and in the next 45 minutes waiting for my troponin is to figure out whether I was having that heart attack or not. And, you know, thank you, Lord, I haven't had one. So, really important component of this is by 2030, there will be 77 million of us baby boomers out there. We're turning 65 at a rate of 10,000 a day, and this is incredible, guys. And we have multiple chronic illnesses. What do? So then you look at the fact that a lot of the baby boomers are in rural America, and proximity to them, and proximity for them getting in for medical attention is incredible. Think of a 75-year-old grandma, Grandma Shirley, who lives in Neely, Nebraska, who goes in for a CHF, she gets discharged to home, and her family is in the urban area in only Omaha and Lincoln, that's the only urban areas around. And she gains 3 pounds in a day or 5 pounds in a week. What do? How do you know this? That slippery slope is costing us money. That slippery slope cost you guys all this money about me going into the emergency department that many times. The doctor-to-patient ratio is incredibly steep. And the only way to deal with this is through technology and scalability. So, measurable results and outcomes. What do I have to present here? Well, I'd like for you to look on the top left and the top right. These are my medical records from Epic. This is information that from my lipid panels and my A1Cs are embedded in the system. And underneath those, I have graphs from my solution, my product, my vitals. And it'll show my blood pressure and my blood sugars. If you'll see on the top left, my lipid panels since 2011 have continued to improve. Total cholesterol from 121 to 101, my HDL from 39 to 44, my LDL from 72 to 48, my triglycerides from 51 to 45. Those are astounding numbers. I think so. My first year of blood pressure measurements, I was 134 over 81 and a half. My second year, I'm at 160, 120, excuse me, I looked at the 10-minute, 126 over 69. My blood sugars in the first 6 months of this year averaged 133, and now in the second 6 months, they average 116. As you can see, my A1C levels have gone from 2011 from a 9.4 to the last year I have kept a 6.0. You know this well. And that's a struggle, guys, because I'm a diabetic, I'm 62 years old. I have to maintain this blood pressure to blood sugar ratio, and it's very difficult, and you have to look out for, you know, low blood sugars. This is my company, My Vitals, and this is what we do, from remote patient monitoring to the telehealth to mobile health apps and predictive analytics. I have here, one of the big things is that being able to monitor myself daily at home. This is what I've been able to achieve, and I'm seeing those measurable results in the best possible environment a patient can be in their home, in their comfort. And also, I've been able to, as I gather this data, I'm actually able to take and act upon that information with my doctor and my healthcare team, which is very important. Acting instead of being reactive is so much more important. As you see in my product here, I've developed a set of tools which address some of the issues in a host of healthcare complexities. Now, I'm talking to you, and I know that over the last 5 years, you guys have been inundated with changes. Some of those have been mandated, and others just because of necessity. It's a lot of stuff that you guys have gone through. My next slide, whoops, I'm sorry, well, these slides here, excuse me, these are examples of solutions designed for myself, and they're now being used by others. From the home health side, we're dealing with 77 million baby boomers. From the telehealth side, the Veterans Administration last year had 717,000 veterans on the telehealth program with over 1.5 million touches, including mental health. This was extremely important to be able to take care of people from a widespread spread across the United States.
Justice, are you talking about two-way video communication?
Absolutely. 2 and 3 and 4. So you're able to take and have a veteran or an individual who, from any mobile device, tablets, Androids, Apples, platform agnostic, be able to take and call into a triage nurse and have that triage nurse determine whether you need to talk with a doctor. And I don't care where the doctor or healthcare team is, you can get a hold of them and be able to bring them into that scenario and into that conversation. It's extremely important. I do want to mention really quickly is that I will be next door between 2 and 3 o'clock. I'd like for you to stop by to see some of the characteristics of our system. I wanted to tell you one of the solutions is a mobile nurse. And this is set up and designed for disaster arenas where you might be the Red Cross and go into a disaster where you're able to take information immediately on the fly and be able to get medications and take their biometrics. But also, we've been accepted with Catholic Health Initiatives. We are initiating a program in Omaha, Nebraska at the Bergen Mercy Heart Failure Center. We're also working with Nebraska Medicine, which you know is probably one of the 4 Ebola biocontainment units in the country. They are utilizing our thermometer in the hub to be able to care for the staff and take their temperatures for the 30 days following any possible exposure. And the Mayo Clinic with the cardiovascular and transplant team, which are looking for LVADs, which is the left ventricle assist device. I want to ask you guys, you all have a different perspective on this. You have providers, your providers, your insurance companies. I want you to think about use case models where maybe you can think of something in some place that this would really be valuable and useful. I just will tell you from my perspective, you know, this gives me peace of mind. I look at this every single day. So
it helped you to manage your own care.
Certainly did. It's a meaningful use. It's because I participated in my compliance and my health care what we're all looking for is to have that patient as engaged, not sending them home and you tell Grandma Shirley, I need you to exercise 30 minutes a day. And she comes back and says, I did, and she walked down the halls. We need to know, we need to be responsible for our own health care and not to lay all the blame or the issues on our providers. We need to be involved. That way, we can do something with it. Thank you, Abby.
Thanks for that little niblet, Justice. And for those of you who really want to see the system in action, I was pretty blown away by it. He's going to be in the Thomas room right after this is over and show the functionality, which is, I believe it really is the future. And with that, Justice, thank you for making the trip from Nebraska. So Dr. Revelo is going to introduce Dave Watson and team. And I'll just say that after Justice became a complex patient, he needed to move near where his family support system was. So he now is living in Nebraska, so he didn't have to drive from Silicon Valley. He actually flew out to help us understand a new way of thinking brought to us, really compliments from Silicon Valley, since he can work from anywhere. Thank you again.
Well, the 10 inches of snow wasn't a deterrent.
Thank you. So, very interesting information, and I think to build on some of that, which I think, you know, as I think Hattie talked about, we've talked a lot about the importance of exchanging clinical information in the future. Part of meaningful use is to exchange clinical information, and I think what we are interested in trying to bring forward is what is out there in terms of the latest in the health information exchange arena, or the health information exchange world. And so we're very excited to bring David Watson and Ms. Andrea Lieb to talk to us about the CalIndex, which, as many of you know, is the new in the marketplace as one of the major health information exchanges that has been supported by Blue Cross and Blue Shield. It's not part of Blue Cross and Blue Shield, it's a separate organization, but it's pretty exciting to hear what the plans are for HIE across the state and how Sacramento might be involved. So in your packet is, of course, the bios for all our presenters. So David, first of all, clearly has a unique experience working with, starting out with organizations like Kaiser, and then moving to Med Analytics, and also having experiences in Oracle. So he comes to us with a pretty significant background, and he is the current CEO of CalIndex. And Andrea, who is a lawyer and has an extensive experience working with LA Healthcare and other major organizations, and has a really great perspective that she's going to help us understand in terms of the chief privacy officer and some of the issues around the concerns around what's going to happen to this health information once it's out there. So I'm going to turn it over to both David and Andrea, and they're going to talk to us about CalIndex.
And I'm going to throw in that Andrea was also an emergency room nurse and has family history in this area as well. So she brings a really rich perspective that we hope that she'll keep bringing back to us.
Thank you very much, and thanks for the opportunity to speak to you all today. CalIndex, as Dr. Arvalo mentioned, is new. If I were in Silicon Valley, we would be telling you we're coming out of stealth mode, which means there's only one or two of us and not enough to take inquiries. So we actually just added another 25% to our employees. We're up to, I think, 11 of us now. So the company was announced in August of this past year. As noted, it's an investment made by Blue Shield of California and Anthem Blue Cross in order to provide a statewide health insurance exchange program for California. Now I'm a native, And other than 5 years away in the Marines, I've lived here my entire life. So, and I've been in healthcare for 25 years. So, any of you think I'm the first statewide HIE in California? Don't raise your hands. I'm not. Several attempts were made in the early 2000s, all of which did not succeed. There are a number of other HIEs in California today, RIM 19 or 20-ish. They're all regionally based. They were all initiated by local provider community by and large, and were done so in order to meet the needs of that locale, San Diego, Inland Empire, Santa Cruz, others. Our goals are a little bit different. I'm going to touch on that for a few minutes to help you help you understand what we're about. Invested in by the two. They are my first two participants. We are in the process of loading their data. So when we're done sometime in the next month, I'll have approximately 10 million patient records on Californians derived from the two payers, which is the medical information, medical RX lab data from the claim records. We are just now beginning to engage providers in order to sign you all up and contribute similar data from the EMR environment so that we can achieve a different value proposition, which is the convergence of payer and provider data. An example, the value of which I will give very simply, which is, many of you know what, well, all of you hopefully know what scripts you've written. You don't always know what scripts have been filled. That's the domain typically of the payers and the PBM data that they possess. By bringing the two data sets together, you could look in the longitudinal patient record in CalIndex and understand that A, your script is in there, but as importantly for you, you can tell whether or not your patient is adherent or not. And Andrea, when she comes up, has some use cases to demonstrate that. But by knowing whether or not the prescription's been filled recently, instead of guessing around the adherence question, you can actually operate on a fact basis. And that's the goal we have for bringing the data together in CalIndex from payers and providers and creating this longitudinal patient record, which is part of our founding mission. So it's actually data, resident full-time in CalIndex. So it's a repository-based model. Many of the HIEs are federated, which means they broker transactions between the players, but don't necessarily hold any data other than the master person index for identity. We actually hold that data, and our job is to provide the HIE on a statewide basis and to acquire, curate, and manage that data into a longitudinal patient record. And our goal is to get LPR on all Californians over time.
LPR?
Longitudinal patient record.
If you could maybe just say the words out for those of us who don't live in the world of HIE,
Okay.
That's going to help with this crowd. Thanks.
Great. So our goals at the bottom, we want to be a trusted source and a secure source for you to access this type of data that you probably do not have access to today. So if you're a provider, the payer data that's in there, you can mine that. And for the payers, the provider data they may not be getting today so that they can work with you on care coordination and population health issues would be available for them. Having a common data set under a common data model with the data attributes worked out inside CalIndex is, we think, a fairly significant value proposition as opposed to exchanging dirty data with each other where you don't know whether the data you just got is Dave Watson as in me or some other Dave Watson. Okay? Because patient identity is still a pretty significant issue for the exchange and useful use of the information. We talk about completing the system of care. I was fortunate to be at Kaiser for 7 years, and I was their CTO when Health Connect was implemented. So going from the environment that we had, which had quite a bit of automation applied to it, to an electronic health record that was shared across the system, was the first step in actually creating a care system broadly. All of you, I'm sure, have made significant investments in EMR and other clinical technologies, and the payers have been in this space with their claim systems and other care management systems for quite a while. On an enterprise basis, you've all made these investments. But the last mile and the part that we are focused on is to complete those connections between you as providers, as physicians, hospitals, and the payers, so that you can share this data to improve care. And there is a pretty good value proposition that I took away from my Kaiser experience around that common access to data, driving improvements in care that drives our motivation for what we're doing with CalIndex. Again, the data is our asset that we offer to the participants. The Converge data has a significantly higher value proposition than just data from one or the other community. And it does support the emerging models like ACOs and other risk-sharing arrangements, which drive the need to share data, to drive better care, and to take costs down. A number of you in the room, for example, Blue Shield, when I was at Many Analytics, we helped support first generation ACO analytics with you, and others have demonstrated that that coordination between payers and providers and taking the distrust down between those players is a pretty potent way to improve the care that's delivered to the patient, who's the one that matters in the end. So, here's your question. Please grab your devices and take a moment and respond. And in order to get the answers, do I just advance? Okay. All right. If you said false, you're correct. Neither HIPAA nor CMIA prevents you from contributing patient data without consent. You do have to acknowledge your uses of data in your notice of privacy practices, but you do not, there's no requirement for an opt-in by you with your patients in order to contribute that data to CalIndex. It is one of those things that people hold different views, but under the law and regulation in California, that's the correct answer. What we do, I will expand on that briefly, and then I'm going to turn it over to Andre to talk about a couple of use cases. Under the law for treatment, payment, and operations, TPO, for all of you that are HIPAA nomenclature aficionados, you can exchange this data with each other, and you can send it to me as a business associate, and I can hold it on your behalf. But what we do is, because we think it's the right thing to do for the consumers of California, is we use an opt-out model. Not because it's required by law, but because we believe it's the right thing to do for people that have significant concerns about privacy, to give them the opportunity to opt out of their data being shared. And that's the model that we use within CalIndex around opt-in, opt-out, and the question that comes up around that pretty much in every meeting that we come to. Any questions about what the law does or doesn't require in our approach to consumer choice with the opt-out model? There's usually at least one. Okay.
So I have one question about the
Yes, sir.
opt-out. So if I'm a provider and my patient's information is already in there, you house the information and the patient can request that you don't share it.
Correct.
Can they request that you remove their data?
Not from me. That's a request they have to make of the covered entity.
So once it's in there, it's in there.
Yep. And we have, operationally, as a business associate, there's a couple of reasons. One, that's the covered entity's prerogative, not mine. And the request has to come via the covered entity. Second, from a practical perspective, what we've already observed, because we've begun opt-out processing back on October 1st, as we were preparing to load data for Blue Shield and Blue Cross, and we received a number of opt-out requests from consumers, and a pretty significant subset of those have already kind of rethought their initial reaction, and have called and said, can I opt back in? Opting back in if I'm still holding the data but have masked it is a lot easier. I can turn it on and make it available right away without a fairly significant data management exercise to re-extract the data on an individual basis. So there's some practical issues around that as well. That answer your question? Yes, sir.
So just from the standpoint of who actually has the right to see the individual data, can you clarify, what the current understanding is with who has the right to see the individual data?
So this is a list of the services. I'm not going to go through them, but the question you ask is really at the bottom around privacy, security, and data access. So the payer and the provider operate under a set of rules called attribution. And it is the patient attributed to you? For the payer, attribution occurs if you are an active member of that health plan. So for example, I would be attributed to United, because that's who provides my health insurance today. And the day that I'm no longer attributed to United, and let's say I change to Blue Shield, United loses attribution to my record, can no longer see it, and Blue Shield, as of the effective date, can then begin to see my longitudinal patient record. For physicians, for everyone on the delivery side, hospitals and physicians, attribution works a little bit differently. Attribution in that case is date of the last encounter plus 366 days. The reason the physician has a longer attribution period is there's often reasons to go back and look at the record after a visit, and so the way it works is we allow that year period for a provider to be able to relook at the record if they need backup information for claims that are on a run-out cycle with the payer or whatever, okay? And each subsequent encounter then refreshes that attribution date, okay? Patty?
So one of the things that's come up in this room many times, and actually over the years of the Right Care Initiative, so many years in fact that it's on our Right Care Triangle there, is that when you have a team-based model and you're dealing with virtual teams, the lack of functional clinical information exchange is a big problem. So while we have identified through UC Berkeley School of Public Health and many studies, including a white paper by the Surgeon General, that by adding a pharmacist to the care team, you often get much better control of blood pressure, lipids, blood sugar. It would be very important to patient care just to look at sharing that data also with the medication therapy management teams that are often housed in community pharmacies. Could you talk about that issue?
As long as the covered entity who is a participant in CalIndex and who has signed the participation agreement and the business associates agreement, they can authorize any user affiliated with them for access to the system under one of the role-based security models.
Could I, as a patient, say, I would like the pharmacist at, say, Safeway to be able to see my data because I want them to be on my team?
That's not a capability available today. The patient, because we're a business associate, we're governed by the relationship with the covered entity. If they wanted to make a request, that has to come through the covered entity. All I can do is provide access to those people sponsored by the covered entity today. There's a model going forward around that, but I cannot take that access request directly from the consumer.
So we have quite a few questions in the room. Andrea, and then Jill, and then Lisa.
Just so
and then Deborah.
You're aware, the pharmacist.
Use the mic.
We can't hear.
Hold on, is that working? I'm not known for my technical skills. Oh, this one's working. Okay, great. The pharmacist, though, can be a covered entity and can contract directly with CalIndex as a participant. And accordingly, if the pharmacist was part of the system, the pharmacist would have access to the data because the pharmacist would be attributed, that pharmacy would be attributed to you.
Okay, why don't we just go to Justice Decker next, because it's easy on the microphone and he's part of our panel.
Thank you. As a segue to what Hattie had said, with the plethora of EHR systems out there today, Are you using a common interface like HL7? Are you pushing and pulling that information as well?
So with respect to the data access, we do use HL7 interfaces. One of the things that is of very high value from provider side is HL7 feeds for ADT, because then we can do alerting service around, admits and discharges, right? Beyond that, most of the data is handled in a batch mode and is extracted from and ingested by us through a process called extract, transformation, and load. It's a geeky term, but it's basically, we have to do semantic mapping because we hold all the data in standard formats, CPT, ICD, LOIN, RX norm, etc. And that's part of the value is you know what you're going to get when you get it from us because we conform the data. In order to ingest that data, we have to manage the transformation of the data, which is the really hard part, and that's part of the core of our value proposition to the payer and provider community.
So that would make it bidirectional then?
Well, we ingest it, it goes into the longitudinal patient record and it's stored there. The participants can access it via a clinical portal, which I don't want you to get too enthused about my clinical portal because it's a least common denominator approach to looking at a summary record of that individual. The more interesting pieces are application programming interfaces. So particularly the larger health systems, they can actually have their applications make a call directly to consume data out of CalIndex and present it in a screen that you're already looking at as opposed to giving you yet another screen to look at. I know that helped. And then the third one is bulk data download. So a payer provider can download all of the LPRs to whom they are currently attributed and bring it in-house for inclusion in their data warehouse, consumption by analytic applications, and the like.
So Dr. Jill Joseph, I didn't see that, Dr. Ertl.
No, Joe was at it.
Okay, so Dr. Jill Joseph of UC Davis, then we'll pop back to our co-chair, Dr. Ertl, and then back to Lisa.
I'm not sure this is on. I'll stand up and ask the question. Data sharing from this for analytics and research, I believe, is more complex. Could you comment on that at all? And I just might say to the group that one of our new faculty has done a statewide survey of public attitudes regarding HIE for both practice and care on the one hand and research on the other. So if you'd like to know anything about public attitudes, which is, it seems to me that what goes hand in hand with the legal constraints.
It does, yeah.
So could you speak on data sharing for research and analytics?
Sure, so the analytics is, a participant, as I just mentioned, can consume the data for their own analytic purposes. And it's, in essence, they can download some or all of the longitudinal patient record and then use that for their TPO reasons in-house, which can include any type of clinical analytics or others that they want to perform. Specifically around the research case, that's a very different case, so I'll come to that in a moment. But analytics by a participant, they can do anything with that with a couple of restrictions in-house they want, because it's really us providing the data and you unleashing the value of the data through how you consume it and use it, right? And the two restrictions broadly are no resale. You cannot take data that you got from CalIndex and sell it to somebody else. And the other one is you can't use it for market comparison. So if Dignity and Sutter were both in, Sutter downloads a bunch of data, or Dignity does, and then they put up billboards saying, we're better than Sutter. Those are restricted data uses. But other than that, it's up to the participants to use the data for TPO rationale. The research case. On research, we have an intention to provide data sets for research. We have not completed the framework under which that'll happen. That's a future for us. Because until I collect data, there's really nothing to offer the research community. But at a very high level, for research, one, it does not have to be a participant, but they would have to submit a protocol. It would be, we intend that it would be reviewed by an institutional review board function, and that the research request would be either approved or denied based upon guidelines we have not yet developed. And then, if approved, we would generate a data set specific to the research. The researchers would be required to sign a research agreement where they use it for the stated purpose and nothing else, so that we can limit how it might creep out from there. And then we would provide either a de-identified or limited data set to the researcher.
Thank you.
That's the concept that Andre and I still have to build the framework around. Andre may not get to our use cases.
I think we said we'd go to Dr. Erdl and then Lisa Ashton. Then it looks like we have quite a few other questions. So I think what we're going to do from a process standpoint is go ahead and keep the conversation going. It'll just eat into our 25 minutes of discussion time, because this is discussion time interspersed. So we'll be sure that we get the association into. But so with that, Dr. Erdl.
This is one of the questions that I submitted. Typically, health plans have access to data that they pay for. Where here, if they're the attributed person, attributed entity, they have access to the LPR completely. And they have the ability to take all of that LPR and load it into their systems. Therefore, when they're not the attributed entity anymore, they don't have access to CalIndex, but they still have the patient's information from their entire longitudinal record. Is that correct?
Once they download it into their systems, it becomes their data. It's governed by the data use restrictions in the participation agreement with survived termination, but in essence, yes. That's the same characteristic that the providers have, where they can access and download that data, bring it into their systems, and retain them even after a treatment relationship ends. It's the same model. And it's an egalitarian approach to the data that is emerging, particularly through the ACO and the risk-sharing arrangements, because they share a similar need for the same data. And to restrict the payer from seeing history when they're attempting to co-manage populations with the provider is like shooting them in the foot. And so both the payer and the provider in these emerging risk models share a common need for the same data. And so that's why they get all the data to which they are attributed. And yes, whether you're a payer provider, once you've ingested it into your system, it becomes your data and you're responsible for it.
Well, and therein lies one of the problems. So let's say that you've jumped 3 times to different health plans. They've all downloaded your longitudinal patient record into their systems, and you don't know where it is anymore because you've moved on, and then they're hacked. Right? And so this is a big issue for everybody anymore, of the accessibility of the data, where you don't know that health plan X, who you had a relationship with 2 health plans ago, has your data, and now they've been breached. So this is entirely problematic from my point of view.
That's an issue that already exists today.
Yes.
Health plans and providers all have data for people with whom they no longer have a relationship, and retain it, and if hacked, compromise that consumer's information.
But health plans haven't traditionally had the entire longitudinal patient record. They've had the data for which they paid for.
Right. So for me, the notion of they get the data for which they have paid for does not resonate. Because if they have a valid reason for having the data, and your example is a great one, where a person jumps from health plan A to health plan B to health plan C over a period of a year or so, year or 2, right? Then health plan C has to fly blind because they can't see data from previous episodes, which could help them manage care programs that they have and help them be more effective in their interaction with their provider partners, especially as I've said a couple times under these risk-sharing arrangements. So I would argue that the view that I understand the issue of providers distrusting health plans. I've lived it for 20 years, and I've worked on both sides, and at Kaiser I was both simultaneously. But the need for the parties to work together and share data to drive improvements in care, better outcomes, and reduce costs are very compelling. And the folks that we're talking to about joining, it is the ACO and the risk-sharing models that are driving them to acknowledge and embrace this sharing of data, where perhaps it didn't exist before.
So we've got lots of interested coming into the conversation. The next person in line is Lisa Ashton. Then we've got Bill Remack from the Chronic Care Coalition, and then Carolyn Peck from the Department of Public Health.
I just wanted to ask you about the ability for the patient to have access to this information via something like Blue Button or something like that, where they could have access to this information. Because it's really, you've got, I think, 2 of the 3 pieces of the puzzle here, especially around medications. You've got what the doctor ordered through the EMR, you've got what the payer paid for through the claim, but what the last piece of information is what the patient's actually taking.
I owe you money, you're a great straight person.
And so that's the only list that counts, but it's what they're putting in their mouth. So I'm just wondering, is there a portal, or how can they contribute to this, or how do they, can they see this and say, I'm not on that anymore, or that really wasn't me, or,
Currently, they can't. So first stage is to enroll the payers and providers and populate the longitudinal patient record. Our goal is ultimately to give patients access to the longitudinal patient record. And there are a couple of impediments to doing that, which actually includes the law. As a covered entity, as a business associate, I can't just open up access to consumers. There's certain restrictions with the covered entities, and there's legal and regulatory issues that we have to work through in order to get there. But our goal is to be able to work through those issues, ultimately create a patient portal so that any Californian can access their record inside of CalIndex.
That said, the patient could go to their health plan or their provider, much like they can do today under HIPAA, and ask them for a copy of the longitudinal patient record. And they could get what is in there directly, much like
from the covered entity.
From the covered entity. So we don't have the patient portal, but by no means are we barring access to the patient.
It just has to come via the covered entity.
The question about whether the patient can correct the record wasn't answered.
Well, under the privacy rule right now, as it stands, if a patient does look at get their LPR and they say, or any of their records, and they see an issue, then they can go back to the health plan or the provider and say, there's an error in my record. And at that point, as a covered entity, the covered entity will come to us and we will make the correction that's asked for. Again, keeping in mind that we're a business associate, so we need to work with the province, the genesis of the data, which comes from the covered entity. Because as you know, a patient may look at it and say, I've had this experience when I was at United. A patient looks at a record and says, this record is inaccurate, or I don't like the fact that it shows that I saw 2 doctors. I really wanted to only see 1 doctor. So we do need to have some verification that the correction being asked for is an accurate correction. But we can make that, yes.
So we are going to Bill Remack with the California Chronic Care Coalition of Patients.
David, you mentioned this point. You touched on it, but from an operational point of view, if a patient's records are, their payer provider is not part of CalIndex, and now they switch to an organization that is a member, how do they acquire the previous records?
They don't. If the payer or provider that they used to go to is not a member, a participant of CalIndex, I have no basis to acquire their data. They must be a participant in order for the business relationship of covered entity, the BAA, to be in place so that I can hold that data for them. Otherwise, I have no right, and there's no contractual or regulatory opportunity for me to acquire it other than directly from that payer provider.
Well, couldn't you make an arrangement directly with the patient who says, I, Hattie Hanley, wants to have her data in the cloud. I am not like many other people who are concerned about
Not as the way we currently organize the information, because there's a set of restrictions that govern how we operate under HIPAA between a covered entity and a business associate, that there are some pretty tight rails that say where I can and cannot go, and that's one of those. You know, people try to, I'm gonna touch a third rail here. People engage me all the time about, well, I'm the consumer and I own my data, and I want it to be done the way I want it to be done. Okay? I don't respond to that directly, in as much as it's not relevant. I know who possesses the data. I know under which circumstances I can legally acquire the data from them and make it available to the other participants. Ownership is at this point a red herring and something that will have to be dealt with in law and regulation. It's not something I can address operationally.
And it's a perfect segue to Dr. Carolyn Peck from the California Department of Public Health, who has a great deal of authority in this area.
Well, thanks, Patty. My question for you, David, and is really, there are some requirements in the ACA that meaningful use reporting is done to the health department. And so if we have the ability to accept data electronically from you, is that a use, or can data from your database be given or pulled or pushed to the health department?
So the answer is it depends. And we'd have to actually talk about the use case, because my issue is it has to fit within the legal regulatory boundary. And as long as we can create the right permitted relationship for you to draw that data, then we can have, that's the conversation we would want to have. But part of the value that we see is once we've aggregated the data, all the different reporting like HEDIS and STARS and all that stuff you guys have to do, if the data's sitting in CalIndex, why not simply consume a reporting module that we might make available at some future date? So there's a future opportunity, as yet undefined, kind of like the research question, around what are meaningful services we can offer to you to consume that data through potentially applications and then get the result out rather than you simply consuming the data from us. So love to talk to you afterwards because I think there's some good use cases in there around that. Yes.
So we have one more question before I think we should let Dave get back to his presentation and hear from Andrea. And this is a special new addition to the Right Care team. Dave Magnino had been with the California Highway Patrol. He is now working for the Sacramento Emergency Medical Services Authority that oversees the ambulance services. He comes to us via Dan Smiley, who many of us know is the longtime guru of all things EMS for the state. He couldn't be with us because he's out of the country, but he sent Dave Magnino, and we're looking forward to working with you.
Thank you, Patty. Ms. Watson, your presentation so far today really interests me because I was introduced to Health Information Exchange about 2 years ago by Dan when I worked part-time for him on a grant. But my question to you is, everything so far is in-hospital or the payer. Have you thought, or is your future to bring in the pre-hospital providers? Because that is where 99% of in-hospital patients start. And right now, Sacramento County is not one of those regions that has an HIE system. We have 4 systems. We can't even break the door. We can't even get the door cracked open to start talking with those 4 systems about doing real-time field hospital data exchange.
Could you elaborate, please? We can't even get the door cracked open. Could you please?
There are 4 systems in our region, health systems. They all have their own health information exchange or among their systems, where they talk to each other in their systems, but they're all 4, best of my knowledge, 4 individual silos.
Right.
And I deliver patients to all 4 of those silos, but none of my field patient care reports will be accepted on an electronic version into any of those systems. And that's what I mean, we can't even get the door to crack into those systems. We would love to, and I'll do everything I can from my aspect to do that. So that's the key, that's what I'm talking about.
Well, and you can't get real-time reads from those systems to your people in the field either.
Correct, but
So-
that's what I want to start with.
So one of the other presentations that we've had here is that, in the right care discussion across the state, comes from Dr. Arnie Milstein at the Stanford Clinical Excellence Research Center, who has found that globally, when you have the ambulance services able to be electronically communicating through, more of the Silicon Valley, using the updated technology, they're able to get door-to-needle time down to 20 minutes because they really include the ambulance on the care team gathering data pre-hospital so that the stroke team or the heart team can be available. So we really do need to crack this nut, and I'm not sure who the guru in the room is who's going to do it, but let's hear from one potential guru about that.
So, again, another great transition point. We actually have a use case with EMS involved because it's one of the areas that we're very interested is in being able to expose the longitudinal patient record to both the ED and EMS so that when you're at the patient's side, in their home, at the roadside, wherever, you could actually understand that I'm mildly hypertensive, here's my meds list, and oh, by the way, Dave's allergic to penicillin, right? That's very useful, right? So there's a couple of use cases that I'm going to turn over for Andrea to go ahead and touch on these, but before I do real quickly, just so that you understand, we're coming out of our startup mode, we've been loading data, as I said earlier, and this is a very high-level view of where we are in development. We're in that initial deployment of the platform. It's in production. We've got almost 5 million records loaded, on our way to 10 by the 2 founding members. And we have begun active outreach to other payers and providers in order to explain how to join, discuss the benefits of joining and all that, so we can actually sign up additional participants in CalIndex and grow the number and the quality of the data in the longitudinal patient record. And then we have a commitment to create both a product and a privacy work group to advise us on these 2 topics as we begin to build out. Second half, continue to grow participation, because if I don't get payers and providers playing at scale, one, I won't have a viable economic model to grow into. And that's been the prime failing of most HIEs, is they don't have a revenue sustaining model when the grant money, or in my case, the investment by the 2 founding members runs out. And then we'll begin to look at additional product features. We've been talking to Dan about participating in
Dan Smiley?
Yeah. Pulse.
Yeah.
I got all these acronyms in my head, and I had an acronym moment in Pulse. And it's the other data sets that expand the functionality of the patient record. We've been in conversations with the California Healthcare Foundation when they automate Pulsed, being able to expose the Pulsed data through the longitudinal patient record, because it being paper isn't all that useful right now, and we all know that. Other registries can come to mind, whether it's hips and knees over UCSF and some of the other registries that can, again, extend the data. But specifically, there's use cases that I know that Rim will talk about when he affords his broader perspective from KHI and some of the other HIEs who began development before we did, who are doing work with EMS, but it's clearly an area we're interested in. And with that, I'll introduce Andrea Lieb, and she'll take you through a couple of use cases, and I'm sure we'll have a lot more interaction here. Thank you.
Yeah, these are kind of high level. I think Hattie mentioned I had been an emergency room nurse, and I was an emergency room nurse for about 10 years, and then I've been a privacy and healthcare lawyer for about 20. So I'd like to say I was about 5 when I started.
Do you want to say anything about your family
Well,
experience?
I'm going to get to
Okay.
that. Don't worry. In addition to being a nurse and a lawyer, I'm also a caregiver. And I think that's what brought me to CalIndex, why I came here, was because I learned what not having data can result in. And the stroke use case is what I like to call my personal fairy tale. that maybe if it had worked out this way, I could take the caregiver part out of my life, but, and just be a daughter. Anyway, Jane Doe in this is a 72-year-old female, and she's out to lunch with her friends when she gets up and she loses consciousness. And her friends call 911, and they say Jane Doe's lost consciousness. And she regains consciousness, but she's slurry and a little bit confused. The EMS providers come. Now, in this case, the EMS providers are CalIndex participants. And although the EMS providers may not be attributed to CalIndex, CalIndex does allow for a breaking of the glass, or an ability for emergency providers to see information on patients in a true emergency. And so the EMS provider in this case is able to, once the patient identity is established, they're able to look at the LPR or the longitudinal patient record that's in CalIndex. And when they look into the longitudinal patient record, they discover some things about Jane Doe. They discover that Jane Doe has had a TIA in the last 6 months. They discover that Jane Doe has a history of hypertension. They also discover that Jane Doe is not a diabetic. She doesn't have a history of seizures, and the LPR kind of shows that she hasn't been treated for any kind of head trauma recently. So when they look at this and they assess Jane Doe, there's 2 hospitals, and one is closer. The other is a little bit further away, but Hospital 1 is not a center for stroke excellence. Hospital 2 is. So the EMS people are armed enough to make a good decision to take Jane Doe to the Center for Stroke Excellence. As things continue, they're able to call the hospital and notify them that Jane Doe is on the way. The hospital also has the ability. Hospital is also keep in mind, this is my case, a happy ending. The hospital is also a CalIndex participant. And although Jane Doe has never been at this hospital before, because she usually goes to the nearer hospital, they are again able to crack that seal, and they are able to notify the rapid response team, and they are able to find out all of this information about Jane Doe, including her emergency contact information, her husband, who is available by cell phone. And they see all of this information, and as they start looking at order the prompt lab, order the prompt CT, and with the information that they got and the ability to contact the husband, they are able to assess that a stroke did occur in this case. And Jane Doe is given TPA, as opposed to perhaps if she'd gone to the other hospital without this information, they would have said, oh, well, is Jane Doe a head trauma? Did she just fall and hit her head? What is going on with Jane Doe? So she gets that. I didn't do it in 20 minutes because I'm a former ER nurse and I'm realistic about 20 minutes seems so close to me. When I was reading the stroke protocol, and I kind of read it, it's been a long time. So I looked at it and I thought, well, 2 hours. In Jane Doe's case, using this system, Jane Doe doesn't suffer permanent injury. Jane Doe doesn't cost the health system months of rehabilitation and ongoing. Jane Doe doesn't have to disrupt her life and move across the country so that she can be closer to her caregivers. Jane Doe has minimal interruption of life and goes about her business. So that's the end of the stroke use cases. But this is why we really believe in CalIndex and why I came here to become the Chief Privacy Officer. So I'll give you a shorter one. And this one Dave alluded to. This isn't a family member. And Jack is a newly diagnosed 42-year-old male, type 2 diabetic. Dr. Smith describes an oral hypoglycemic, maybe one made by Novo Nordisk, along with a statin for cholesterol. the patient gets an initial 30-day supply as well as a, goes to that pharmacy, fills out his initial 30-day supply. He's supposed to come back for a follow-up visit with Dr. Smith, but he cancels a couple times. And then around 83 days, he shows back up in the office. And Dr. Smith says, well, have you been taking your medicines? Oh, yes, I have, and I've been compliant with my diet too. Dr. Smith looks at his A1Cs, and they're above 9. His cholesterol is still elevated, as are his triglycerides. Are you sure you've been taking your medicine? Oh, definitely. Dr. Smith now has, in addition to having, as Dave alluded to, in addition to having the refill, you really have to be taller for this, even with heels. In addition to viewing his own notes, he's able to see from the refill refill history that the health plans have provided that Jack Doe has only filled out the initial 30-day supply. So instead of having to sit there and go, oh, well, is this medication wrong? Should I change the dosage? Dr. Smith can really identify this is an adherence issue. This is a drug adherence issue. So those are kind of the two use cases that I came up with as I was going through this. And I think they do make the point that, information is gold in this industry. When I was a registered nurse, or I still am, but when I practiced, we still were on paper notes. And when people came into the ER, we had no idea what was wrong with them, what their history was. And we don't live in that world anymore. We live in this great world where we have all this information available, both for the primary care physicians, for the ER, and for the health plans. So CalIndex gives us that opportunity. And so that's it for my little spiel. But does anybody have any questions? Any additional questions? I was asked to address really quickly the breach, the Anthem breach, which I know Dave addressed. And as we said, we're a separate company. Our data was not breached. It's completely different. Just one difference, and I think that our data is at both in transit and at rest. We encrypt our data, so we hope that's moving toward greater security. Also to note, as we may have noted, we don't take financial information. So we don't take that social security number or any other financial information. Our purpose here is to provide healthcare information and to provide communication between the payers, the doctors, and all of you who are providing clinical service to the members, and in the future to the members. So thank you.
Thank you. So it's my pleasure to introduce Dr. Robert Cochran, who is currently the Executive Director for California Association of Health Information Exchanges. He has a bit of a background. He's been in this line of work for a bit. So undergraduate degrees in biology and chemical engineering from MIT, PhD in medical engineering from the joint Harvard-MIT program, clinical research at the Cleveland Clinic. Then he was assistant professor for biomedical engineering at the Ohio State University. Then he was director of Center for Medical Imaging Analysis at TRW, chief scientist at Northrop Grumman and was involved in the prototype architecture for national HIEs. He then was director for clinical information services at Northrop Grumman, and then chief technology officer at Cognosante. Is that correct? Yeah. Cognosante, which was sounds like a bunch of people from Northrop Grumman who moved over, in part. and then Chief Technology Officer at Cal eConnect, and then Director of California Health and Quality at UC Davis before his current position. He's been a member of numerous boards and is exceptionally well thought of in the industry as far as health information exchanges. So join me in welcoming Dr. Kaufman.
Thank you very much. Actually, it just sounds like I couldn't hold a job. I don't think that's quite the case. Yes, I've been involved in health information exchange for a long time, and currently the executive director at the California Association of Health Information Exchanges, or CAHI. First of all, the name is not my fault, so don't blame me for the name. It is a real mouthful. And CAHI is also the statewide health information exchange in Kansas and the statewide health information exchange in Kentucky, and we are neither one of those. So what is CAHI? I would say that primarily my job today is herding cats. CAHI is a voluntary collaboration of a large number of stakeholders across the state of California. About a third of our membership is not-for-profit or community health information exchanges. About a third of our membership are enterprise exchanges, large health systems that exchange information among themselves. And about a third of our members are not health information exchanges at all, but are organizations that are very interested in promoting health information exchange. Some of those are state agencies, some of them are payers, etc. Interestingly, at least for our conversation today, we should revisit what happens in Sacramento, because before health systems in Sacramento are all members of CAHI, as is CalIndex, and the California Emergency Medical Services Agency. So there is the collaboration that should be solving the problems in Sacramento here. Part of what we do is provide a community-wide participation in what's going on at the state level and at the national level. As an association, we respond to calls for information come out either at the state level or at the national level. For example, we just put in a letter last week responding to the Federal Health Information Technology National Strategy. We're currently reviewing the interoperability roadmap that ONC just published, and a set of standards they've identified as the most appropriate standards for us to be concentrating in. So we provide a common voice for our members here in California. We also participate in pilots, and we'll talk a little bit more about POLST and PULSE, both of which Dave mentioned just during his talk. We also provide a forum for organizations to get together and share ideas. We have a very varied membership. Includes, for instance, the Santa Cruz Health Information Exchange that is coming up and celebrating 20 years of successful exchange in their environment, all the way to organizations that are still looking forward to their first day of exchanging data. And there's a lot of success that can be shared among those organizations, and an opportunity for them to solve those problems together. What that means is we're trying to address some of the difficult problems in health information exchange. We just recently held a webinar and have a working group now specifically looking at how do you exchange sensitive data, respecting privacy, and state and federal regulation around how you treat that data. We're looking at the integration of emergency services. We'll talk about that a little bit more. And one of the big problems that David already alluded to is how do you deal with ensuring that we're all talking about the same patient when we're exchanging information or doing patient matching and managing patient identity. Part of what we do is also self-governance of statewide health information exchange. And CAHI actually came into being a little bit over a year and a half ago when the state of California brought a number of stakeholders together and said, we need to figure out how we're going to manage things in California. As David said, there are a large number of health information exchange organizations in California. Depending on how you count, there might be as many as 35 in the state if you include enterprise organizations or health systems that are exchanging information among themselves. And how you deal with the fact that what we've done through high-tech and the incentive program have merely moved us from islands of paper records to islands of electronic records, and what do we do about that? So part of what we're doing is enabling those organizations to exchange information with each other. We are not another CalIndex. We don't hold any of that information, but we are enabling organizations to exchange information across their boundaries, and that's what our goal there is. So Dave and I get along well because we're not treading in each other's spaces, but instead are helping to enable each other to do what needs to be done. So what do we do to help actually make things work? Part of our job is to ease the exchange of information among organizations. As I said before, what high tech and a lot of what's happened in the last few years has done is moved us from paper to electronic information, but that electronic information is still in a place that's inaccessible. If we return back to the question about how do I get information or share information in the pre-hospital setting in Sacramento, and there are 4 organizations here that don't actually play with each other very well. That's one of the things that we're trying to do. And it turns out that those organizations are beginning to move forward to exchange information with each other. And we're having conversations now with Dan and other members of the EMS community about how we can better enable health information exchange. So one option is, as David suggested, is that EMS might become part of one of the health information exchanges, and you find, for instance, down in San Diego that that's absolutely the case, and they're very successful in integrating emergency medical services with the health information exchange in San Diego. That ain't going to happen here in Sacramento because there is no community exchange in Sacramento. So that means we have to figure out other mechanisms to cross those organizational boundaries. I talk with my hands, I'll try not to hit the microphone. So that's part of what we do, and we'll talk a little bit later on how we're trying to do that. We're also looking at how do we enable exchange in the pre-hospital setting. Now, first of all, that means in day-to-day operations, when we're just dealing with an emergency, how do I get information from one organization to another organization? And so we have a system of policy agreements and very lightweight technology to enable that. And it's really intended to bridge the gaps that we talked about earlier, where we have organizations in a community that are not yet sharing data with each other as part of a health information exchange organization, but do have the will and the means to exchange information with each other. What can we do to better enable that? We're also working on Pulse, and Dave mentioned Pulse just very briefly. Pulse is a project that started out of the Office of the National Coordinator for Health Information Technologies, interested in helping communities address disaster response, and turned to California as an interesting ecosystem to try out a new system. Pulse stands for Patient Unified Lookup System for Emergencies or something like that. I didn't come up with that name either. But the idea here in California is when the big one comes and a lot of people are displaced from where they normally get care, what do we do? And that means that we need to figure out ways that we manage the identities and how providers can get access to health information systems, such as the EHRs that they no longer have access to because they're no longer in their home environment, as well as patients. And that may be patients that were injured as part of the event, or it may be patients that were displaced from where they were already getting care because that area was so hard hit that they had to be moved. So we've got a very complex environment where we need to primarily deal with identity management, the identities of the providers and the identities of the patients, as well as where their data might be housed. We're also working on some projects in chronic care. Now again, if you're just dealing with how do I get information that I need, again, we're sometimes crossing organizational boundaries. When a patient moves from an inpatient setting to an extended care setting, that extended care setting may not be part of a health information exchange. How did they get information? KHI may provide some of the mechanisms to end up doing that. We're also involved in Pulse. It's interesting to actually talk to people on the phone about these two projects, and you almost have to spell them out. Dave and I joke about that a great deal. Pulse is physician orders for life-sustaining treatment. And it's a set of, for folks that don't know, it's a set of standing orders, physician orders that give instructions to how patients that are at end of life should be treated. It's of huge concern in the emergency setting, when you can imagine, for instance, when the ambulance arrives, lights and sirens, and they need to know, do I use the paddles on this patient or not? And they need to know the answer now, and they need to get the answer right when they're talking about patients that change their minds on that answer on a regular basis, depending on how their chronic conditions are going. CHCF is considering sponsoring a pilot of an electronic pulse registry so that we get out of the paper environment where we are now. And you can imagine that such a registry would have a place at a state level rather than in a community level, because after all, you need to ask the question quickly and get the right answer, not the answer for the community that I happen to be in right now, because you know what? My primary care doesn't happen in Sacramento, so that'd be the wrong place to ask that question for me. So we're working with CHCF as well as members in our community to try to address how we might provide an electronic means to get pulse orders. So a little bit about privacy. And there are two really big issues to be dealing with here. One is just the security of data, and I'm not going to talk about security of data very much, other than there is a lot of call and a bit of a movement now to really treat healthcare as the national critical resource that it really should be. That there are standards that most organizations that are critical IT resources hold themselves to in terms of security, and a lot of the healthcare industry doesn't do that. And there needs to be, organizations need to stand up and address those issues. But when we're talking about privacy and security, I think there are some other things that we really need to make sure that we address. First of all, do you know who it is that you're talking to? Both from an organization standpoint and an individual standpoint. When a physician asks an exchange for information, how do I know that that physician actually is who they say that they are? What am I doing to identify them and to validate their identity? Or when one organization in Sacramento asks another organization in Sacramento for health information, how do I establish trust between those organizations? The second is, how do I know that we're both talking about the same person? And anybody that doesn't think about the fact that part of security and privacy is all about making sure that we've identified the same patient, just hasn't thought through the problem quite enough yet. And patient matching and patient identification is a major problem despite the relative maturity that HIE is getting to today. I look back to my time at Northrop Grumman, where for a while, one of the programs that I was charged with was the EHR for the DoD. Probably still the largest worldwide deployed electronic health record. And I wouldn't say that necessarily that program was a great success, but I will say one thing is that we should have had patient matching licked, because we're talking about a system that's integrated with their HR system. We know who these people are, and guess what? They have a universal identifier in Boston metal hanging around their neck. And still, patient matching was the hardest thing that I dealt with every day. And I had a team of people just dealing with that issue. When we're talking about an environment where people are reluctant to show a lot of information, in mobile society where people are moving, where a lot of people share names and may be poorly documented, patient matching and patient identification is a really, really big deal. And as part of sharing solving problems together, that's one of the things we're going to be trying to address.
Is biometrics helping? You know, the iris recognition, thumbprints, etc.
That's a very reasonable question, and potentially. Part of the issue that you're dealing with, there are at least two barriers for dealing with that. One of them is that we still live in an environment where a lot of people are reluctant to share a lot of information, including biometric information about each other. Part of the problem, though, is that we may not have the patient accessible for biometrics in the room with us while we're trying to get information. If the patient is inbound in an ambulance and the ED is trying to get information, they can't do a retinal scan. If the patient is unconscious and being wheeled through the room, I may not be able to hold them for a retinal scan. So the question that you're asking is a good one, because what we do today is first name, last name, gender, and birthday. And guess what? Gender is only right 97% of the time in records. So this is a problem with what we're doing now. We need to be thinking about more creative ways of doing patient management. Absolutely. So what are we doing about establishing trust? And I'd say when it comes to self-governance of statewide health information exchange in California, this is what we're trying to do, is establish trust within among our members to exchange information. So we have two main tools that we use. First is a multi-party data sharing agreement, what we call the CalDERSA, or the California Data Use and Reciprocal Services Agreement. And it is a document that says, this is how I will behave. It tells you how I will use data. It tells you how you know that I can be trusted because of the policies that you and I both share, and how we will use data, how we will identify our users, how we will deal with patient permission or patient preferences for sharing that information. And participants in our network all sign that document. It also calls out things like my rights as a participant in making choices about the data that I share. For instance, the document does say that if I am asked for data, I will respond. My response may be, I have no data to share with you. So I don't remain silent, but I can always apply my own policies because I have a relationship with the patient and they express their preferences with me. I have the responsibility for making decisions about what information I share. The second component is what we call the CTIN, or the California Trusted Exchange Network, and it's a very lightweight set of technologies that helps us establish trust. And so it manages digital certificates between systems and individuals, and a directory of services and provider identities so that you can find providers and you can find the mechanism by which you can exchange information with them. Finally, I just wanted to wrap up with a little bit about the environment in California. You've got to be asking yourself, so why are we doing something so complicated in California? Well, first of all, I still claim that California doesn't really lend itself well to a monolithic system. And unlike a number of states across the country, California chose not to set up a statewide health information exchange, but continue to support community and enterprise exchanges and their ability to exchange information with each other and offer the services that their customers thought were important. And the result is there are a lot of exchanges in California, and this map is outdated, so you don't need to really pay a whole lot of attention to it, other than to notice that there's not 1 or 2 or 3 names on there. But on this map, I think there's 31 different exchanges in different levels of maturity across the state of California. But the truth of the matter is that that's what the country looks like too. There are a large number of community exchanges in the country. Some of them are statewide, some of them are not, in different levels of maturity. And there are a lot of enterprise exchanges across the country as well, including some of the large health systems that are here in California. And they have a need to exchange information with each other, with government agencies, with research registries, with public health registries, etc. So California shares the same problems that the country does. And what is good about California is that we are a good test bed for solutions that might work across the country. And with that, we'll pause in case there are any other questions.
So we had a pretty general question. So, of course, one of the things we're very interested in is how can Sacramento create our own Sacramento-based health information exchange? And how would we start the process of recognizing that there's already some work being done by the 3 of the health systems, because they have Epic, and that's Kaiser, UC Davis, and Sutter, and they use something called Epic Elsewhere, which is a functionality that's already been built and already exchanging information. And actually, Hattie is a good example who has been a patient of two systems and was actually, they used that process. But there's others, of course, and besides, we said 4, but the VA is also here. There's also, a critically important piece is our community clinics, and with, trying to bring those organizations together to be able to start creating those, and recognizing that what I think you said earlier, there's been several other health information exchanges that have come and gone. Santa Barbara is an example, several others that unfortunately couldn't sustain themselves because the big issue is where do you get the money? And so as the executive director, what kind of recommendations do you have for us here in Sacramento as we begin this, again, this process to try to, use the nidus of what we have to actually create a viable, living, and durable, and that's key, durable health information exchange, so we can address some of the issues that were pointed out very nicely in the case examples?
It's a really good question. As the executive director, so no pressure here. What you touched on a couple of very important points there. First of all, it needs to be sustainable. And it takes real serious effort to put a health information exchange together, and if it is not sustainable, then you wasted all that effort and you've gotten nowhere. And it needs to be durable, and that means not only from a business standpoint, but from a technical and policy standpoint, it needs to be durable. What is required to generate any health information exchange is a collection of individuals that have the will to make it happen and see a business or a patient care need that is not being met. I think David would tell you that was what generated CalIndex, is there is a need that was not being met, and here was a potential solution to it. What that need is changes from community to community. So for instance, if you look in Mendocino County, there's a health information exchange that's been there for a long time. They do results delivery. It's all they do. In fact, some people would even claim that isn't health information exchange. If you look down at Inland Empire, part of what they offer there is patient analytics. That's a new service that's not necessarily included in a lot of health information exchanges. So it's what does Sacramento need, and does it have a core group of people that will come together and address that need? What I'd say is, so in the absence of that, what I'd say is that KHI offers an alternative. You currently have an emerging rural health information exchange in the Sacramento area in Sac Valley MedShare. You have 4 organizations, 3 of which have signed the CalDERSA already and therefore have a policy mechanism by which to exchange information, and we're working on the technology mechanism for doing that. Plus, for example, CalINSA that is reviewing the CalDERSA to make sure it's consistent with their own policies. And so there is a mechanism to exchange data if there isn't the business need that makes a regional health information exchange a viable business concern. Because if it's not a viable business concern, it won't be sustainable and you get nowhere. And while our ultimate goal is better health care, it also has to be successful as a business. It just has to be.
So this has been an absolutely amazing day. We are at the 2 o'clock time now, so I need to just say that we need to respect all of these, everybody's time. Everyone wants to continue the discussion. The Right Care Initiative isn't necessarily where that's going to happen, but it was, it's very important to our group that we make progress on that front. Maybe we need to form a subgroup, a work group. I'm not sure what the next steps are there, but I do want to, before we thank our speakers, want to point out to all the clinical people in the room that there is free continuing medical education, nursing education here. Unfortunately, we don't have continuing pharmacy education yet, but Health Services Advisory Group, thank you for providing that to our clinical folks. I also want to say that on March 12th, we are going to have Dr. Michael Dolan from the Gunderson Health System here, who is coming to us from the Midwest. Thanks to Bob Trine for facilitating that. I hope to see you all back here on March 12th for that. I hope we've sparked a lot of important discussions today, and that many of you will join us next door in the Natomas room from 2 to 3 to see this patient-centered two-way data exchange system in action, compliments of Justice Decker of My Vitals, the complex patient who solved it for himself. Bless your heart. And with that, let's thank our amazing speakers.